This is Heidi Nelson, CEO at Duffy Health Center, and welcome to this edition of Duffy Doings, our show where we talk about issues of healthcare and homelessness on Cape Cod and what's going on at Duffy Health Center. Today we're going to be talking about suicide prevention and a new collaboration that's coming to Cape Cod. My guests today are Faith Fusco, Psychiatric Nurse Practitioner at Duffy Health Center, Margaret Deason, who is the Director of the National Strategy for Suicide Prevention Grant for the Massachusetts Department of Mental Health. Welcome, Margaret. And last but not least, Debbie Ciavola, who's the Executive Director for Behavioral Health Services at Cape Cod Healthcare. Welcome, and thank you all so much for being here today. Recently in the press, we've heard about some high-profile suicides, and it's drawn a lot of attention to the issue in our country and in Massachusetts. Recently, the Department of Public Health released new information, statistical information about suicide that draws on data from Massachusetts and compares our suicide rates to states across the country. And it was really almost shocking what we found out. We don't talk about suicide very much in our society, so when we actually look at the issue and look at the data, it can be very startling. Our rate here in Massachusetts is relative to other states, low. We are 48th out of 50 as far as suicide is concerned, but in Massachusetts, our rate has increased by 35% over the past 15 years. Wow. And half of the states in the United States had an increase in suicide of more than 30%. So clearly this is a really significant issue, not only here on Cape Cod, but in Massachusetts and across the country. But even more astounding is the additional statistic that more people die of suicide every year than die by car accidents. 45,000 people die by suicide every year. Duffy is part of a collaboration on Cape Cod to prevent suicide. We're partnering with the Commonwealth of Massachusetts Department of Mental Health and Cape Cod Healthcare to impact the suicide rate, and we're using a national model that we're implementing here at the Cape. But first I want to turn to Faith, who's one of our Duffy employees, and ask her to tell our audience about the work that you do at Duffy Health Center. What services do you provide? And tell us something about the patients that you treat.
Well, in being a nurse practitioner, we are able to provide multiple services because that's what nurses do. I work in concert with an excellent psychiatrist in the mental health department, Dr. Field, and our primary responsibilities at Duffy are to help with diagnosing, treating, and educating the patients that come through our doors. We have a multidisciplinary medical home, and we have a couple ways in which patients enter our system, and we want to be there to, solidify diagnoses, solidify prescription plans and treatment, and connect people to therapies and services that are appropriate for them individually.
Great. So we have our medical clinic at Duffy. Often people don't really volunteer to come for behavioral health services. Sometimes they have to be persuaded, and often if one of the doctors or the nurse practitioners in the medical clinic identifies somebody with a mental health issue or an addiction issue, they'll refer the patient upstairs, as we say, because behavioral health is on the second floor.
Yes.
So interacting with the medical providers, and then also the third leg of our three-legged stool, which is the case management department.
Right.
So many different avenues and entryways to become part of behavioral health. And our psychiatry team works very close with our therapists at Duffy, so people get counseling as well as medication.
Correct, yes.
Or one or the other. They can pursue that. Very good.
A good team.
Have you ever had a patient who expressed that they might have a wish to commit suicide, and how do you handle that?
Well, I've been doing this for like 27 years, so I indeed have had that experience and challenge of sitting with someone who really is feeling that desperate that they want to end their lives. And it's just very important to immediately focus on that perspective of the interview at that point in time, determine how that individual is feeling currently, look at some of the history around safety with that individual, try to understand what supportive services are in play in the individual's lives, if they're connected to family or perhaps even a spiritual connection. Try to identify that. You really question, and you try to determine where they are in regards to their thinking pattern. Is it a thinking pattern where they might have some fleeting ideas once in a while with no specific plan at all, and maybe intensive therapy or referral to a therapist immediately, kind of closing in the resources around that individual, create a holding pattern for them is real important. And then you might get to another extreme where a person is really determined to end their life. And at that point in time, you pull in resources for emergency care and inpatient admission to provide the patient with safety and treatment until they're able to pull up their own safety reserves.
Right. Well, and also to reinforce the fact that they came forward with these feelings and they told you about it. That's a very brave thing to do for somebody
it really
to make
is.
that admission.
Yeah, and reinforcing, the engagement at that point. Engagement is such a crucial part of, I think, helping people to remain safe. So really engaging and talking about what it means for them at that particular time to be feeling like that. Yeah.
Well, this is a good time to turn to Debbie and ask you about the services. Faith mentioned that often somebody who has thoughts about suicide may need to be hospitalized. And so can you talk about the services that are provided at Cape Cod Healthcare?
Thank you for having us. First, I would like to say we're very fortunate to have a president and CEO that has supported behavioral health significantly, and in the last 5 years have grown from a smaller department to a much more robust department that can meet the needs not only of the hospital and of both hospitals, but the community as well. So we have a 20-bed inpatient psychiatric unit. It is a locked unit. We have partial hospital that can have up to 20 patients a day. We have an outpatient in Harwich, Hyannis, and now Falmouth that has serves over 30,000 patients a year, and that's again meds and therapy.
Wow.
And then we have we developed a consult liaison psychiatry service for our medical surgical floors of both hospitals, whereby a board certified consult liaison psychiatrist is somebody who's boarded in both medicine as well as psychiatrics. And they do real-time psychiatric evaluations and treatments on the medical surgical floors, and that's about 2 years old. And then we have now a telephone consultative service, so PCPs throughout the Cape Cod healthcare system can call and get
Primary care providers can
I'm
call.
sorry.
No, it's
yeah,
all right.
primary care providers. Sorry, we have more acronyms than that sometimes I don't even know what half of them are. They can call in real time and get a psychiatrist. So you might have somebody in your office, or you might have dealing with a very critical situation, and we'll get a live psychiatrist who'll help walk them through it and give them the support that they need. And we also started a bridge clinic that's related to people being discharged from partial and inpatient, that they will be seen within 3 days of their discharge.
Oh, that's
so
a
that
great
we can,
goal.
yeah, so
Wow.
that we can do a check-in, make sure they're stabilized, make sure that nothing has changed, there's no social issues that have come up, and if there's any barriers to getting to their appointments. But the largest improvement, one of the largest improvements I believe we did, is we changed the care, how patients go through the system. So we created a system in our emergency department, which you've been very instrumental in that as well, where we embedded a team of psychiatrists and nurse practitioners and physician's assistants to, once the emergency department physician medically clears them, they're admitted to our service. We provide a comprehensive psychiatric evaluation. We do a med reconciliation, which means we check all their meds and see how we can best help them. We stabilize them, refer them to treatment if they need so, or we discharge them, and frequently call you.
Right.
So that's made a big impact, because a downstream effect which we didn't expect, since we have the only 20 beds on the Cape.
Right.
It's by stabilizing and helping patients to either go to partial hospital, to your services, or to other services. We've saved the beds for the most acutely ill on the inpatient unit.
That's right. So another significant role of the hospital is the emergency department, as you were mentioning, and people coming in crisis, really, with serious mental illness and substance abuse issues. So talk a little bit more about how the hospital interacts with the community in that very important role when people are in a crisis, and how does that fit into our community?
Cape Cod Healthcare has really worked at integrating the community into all the work that we do, whether it's through grant funding or participation, but it's frequently the point of entry is our emergency department. Mm-hmm. And which is a significant amount of people seeking help. And it's hard to get behavioral health, and it's hard to admit that you might need some behavioral health, but the people that come in are generally having psychiatric emergencies. So we actually have social workers that help find out if there's any social barriers or problems that are going on at home. We have people that reach out, as you know, to Duffy and to other organizations. We've tried to strengthen and collaborate in those relationships as well, because we can't be all things for all people. We don't have, by gathering and linking all the resources, it makes for a more well community. We also participate in funding in WellStrong for recovery. We we actually did grant funding for first responders for mental health training, which helps in the community, so the EMS or ambulances or firefighters or police are all being trained in how to respond if somebody's in a psychiatric emergency. So we're doing multiple things to help support the community in mental health, but we want to be a part of that as well.
Right. Well, and now's a good time to talk about the role of government in addressing these problems and these issues. At the federal level, there's a department called the Substance Abuse and Mental Health Services Administration, and they provide grant funding to implement models that work, that are evidence-based across the country. And that's your job, Margaret. So do you want to tell us about this evidence-based practice called Zero Suicide?
Right. So Zero Suicide is it's a couple of things. I mean, one thing I first want to acknowledge is it's an aspirational goal. It really is called Zero Suicide because one does not want to aspire to anything less than zero suicides. And so we're really upfront about that as being an important element. The other thing that Zero Suicide is it's a systematic approach to working with healthcare systems to evaluate how you currently address suicide prevention and offering a method for implementing evidence-based practices and sort of the best practices for addressing suicide prevention within a healthcare system. So SAMHSA has endorsed it as sort of a model across the country, and they've been supporting grants to states to help states disseminate the model and to help states help healthcare systems implement the model.
So one of the issues that we face, and everybody's working very hard every day in healthcare, nobody doesn't communicate with somebody because they don't want to. It just is the way our system is set up, if I'm making sense to say it that way. And so we find ourselves with a system that can be fragmented at times and have poor communication, especially between institutions. So how does Zero Suicide address that?
So Zero Suicide, actually, I think maybe the answer is sort of how is Massachusetts approaching how to address that? And because Zero Suicide sort of says you should talk to each other, you should make sure you have methods and procedures in place. And what we've really learned is that it really comes down to relationships. You can have the best technology in the world, you can have the best resources in the world, but the more that you have people at the table talking with each other, recognizing what each other has to offer, the better you're going to be at working collaboratively together as a system.
Yeah.
So on the Cape, we have Cape Cod Healthcare, we have Duffy, we have the Samaritans of the Cape and Islands, which is dedicated to providing services and support to people who are experiencing a suicidal crisis. Knowing about each other and what each other is able to offer, we can build those sort of supports, and we're better at handing off to each other. Because I think that's the biggest, you mentioned engagement, that sort of engagement is one of the biggest challenges when someone leaves one system of care and has to take that step and enter another system of care, how you support that.
Why did Massachusetts decide to pursue this? I mean, our rate is relatively low compared to other states.
Our rate is relatively low, and our rate continues to rise, as you mentioned at the beginning. And one of the areas that is really recognized as a sort of a missed opportunity often is the healthcare system. So there's a fair amount of data that suggests that people who die from suicide will have had contact with a healthcare provider within the last 30 days or 3 months prior to death. And so we're seizing upon those missed opportunities and really wanting to work with the healthcare system so that everybody can sort of do better to identify, as you said, and recognize when someone's at risk and marshal the resources.
And we had quite an elaborate process for working on this grant, many meetings. Talk more about that too. How did you put that process together?
Well, so I want to acknowledge in Massachusetts, the Department of Public Health is the state agency that largely is responsible for suicide prevention efforts in Massachusetts. And they have had the Garrett Lee Smith National Grant, which is a youth suicide prevention grant for a number of years. And so they actually rolled out Zero Suicide a couple of years ago with several hospital systems in other parts of the state. And what we learned from that experience is that it's not enough to work with a single hospital system. You really need to work with the community that the hospital system is a part of. And so when we learned about the opportunity to apply for the National Strategy for Suicide Prevention grant, it's a mouthful, which really is for adult suicide prevention, we were looking for a community that we came upon the Cape because there's both great need and just tremendous creativity and tremendous wonderful energy that already exists, and sort of a community of care. And so we wanted to work not just with a single healthcare system, but really with a community system to do it well.
We are sort of a fishbowl here, aren't we, in Barnstable County. There's one hospital system and a collection of community health centers and physicians that all feed into the same system. So it helps, I think. And the fact that we have, as you mentioned, the leadership, not to mention Dr. Daria Hansen, who's the Director of Psychiatry at Cape Cod Healthcare. So talking about the model of just picking up the phone and calling somebody, she really models that, along with our medical director and Dr. Field, Dr. Klein. So Faith and Debbie, reflect on what Margaret was saying about what we're trying to do here with the Zero Suicide model. What are you doing as part of this project to address some of those communication gaps?
All right. So one of the first things that we decided to look at was the points of entry with the patients that come into us who may be at risk. And so in identifying that, we wanted to launch a sort of a trial program. So we utilized our current bridge program to start to identify individuals who were hospitalized and perhaps had significant suicidal ideation when they went in, or there was a failed attempt at suicide. And so we have staff members that visit the inpatient areas and speak to the partial program staff, and we're a team with them and we collaborate with them, and we're able to identify individuals then that will have an assured continuity of care coming into Duffy into the bridge program. Once the individuals in the bridge program, we actually have established a electronic medical record flag that we put on the charts, and it's for providers to be able to say, oh, okay, I really need to sit with this person and ask them about how they're doing today. And it's providers in mental health, but it's also providers in the medical field, because we really took the statistics seriously about the last visit in 30 days, or it was with a medical provider, with some of the completions. And so we have implemented that. We have
so people who successfully commit suicide often have been to see their doctor within the 30 days prior to. Oh, that's so interesting.
Yes, and so we felt that the flagging was real important for people to really pay attention to history and really discuss with the patient where they're currently at in regards to their thinking strategies. Another thing that we implemented was an engagement specialist that follows up on individuals if they miss an appointment and they're high risk flagged. So there's again that reach out, that connection with the individuals, because in my experience, quite honestly, people drift off and get on the fringes if they start to get more and more depressed and they start to really have the suicidal ideation coming to the forefront again. So we implemented that. Our team has gotten together and visited safety contracts. We've redeveloped them. And
so that's something that you discuss with the patient. If they're having feelings, what do they do to keep safe?
Right. And who are your resources? And even putting telephone numbers right down on this little plan we create so they can have it with them. Because sometimes when you're thinking about ending your life, the focus is on just that. It's hard to kind of bring yourself out of that position and to really realize that there's other avenues, there are other types of support systems, and you can just pick up a phone sometimes, and if it's right in front of somebody, that's the key.
Debbie, how does the hospital then fit into some of this work with flagging and identifying and working with people who have had an attempt?
I think the biggest changes that we're making, and first I want to say thank you for all the energy you're bringing it to us and helping to stay on track with a very big goal, because it's a large system. And the first thing we did is a suicide risk assessment to see how many assessments were out there. And we're fortunate that we're going to go to another electronic medical system across even the primary care physicians and our outpatient, and every system will be one system. So we are able to identify an evidence-based suicide risk screen, which is already in test mode in our outpatient department, to identify. And then we have also engaged the education department to set up trainings, because there's a competency. We're familiar, we're confident. But if you take somebody in an emergency department, they'll see these people, but to understand really how do you catch those nuances, because someone who's really serious too as well, they're very good at going underground. And so we're doing quite a bit on the suicide risk assessment, and also in the evidence-based, also in the training and education, building staff competencies, and having maintaining those competencies annually as well as initially as well.
Right, that's the hard part, is because there's turnover and just keeping it up and making sure that everybody is, has that level of training in these evidence-based practices.
There's another piece where I thought you had a good question about the death and despair, and and your question was about middle-aged men, and do we or middle-aged people that is there more? Yes, I do think there's more, but there's another thing I just wanted to say is that an area for us to continue to improve upon as throughout the country, but we're seeing a higher rate of suicide thinking in the very young, like 6 years old, to early 20s.
Oh my goodness.
And definitely seen a significant change over the last couple of years.
Right.
And I think that's an area that we can work on as well.
Right. Something that's been out there in the popular press is this idea of deaths from despair, that suicide is an example, drug overdose is another example, where people have problems and issues that just feel so overwhelming to them, and that's what some of these celebrity situations have kind of drawn our attention to. Money problems, job problems. Our society is challenging, challenging to keep a positive outlook, and so we need to have programs like this. Margaret, where are we at in the implementation of zero suicide?
Well, I think one thing to just mention that zero suicide is, we think of it as sort of like a lifestyle change. So it's not a
Like going on a diet.
Exactly.
Yes,
It's not a diet. It's something that you're committing to sort of for life, to be scrupulous in reviewing how you're doing. So one of the elements that's important is using data to look and see, are we doing what we say we're doing? Are we actually screening folks? And when they're screened, are we following up and making sure they're getting the level of care that's appropriate? And are they engaging with us, or are they dropping out and are we missing them? And so you want to have a way to use data to make sure that you're doing what you say you're doing, and that it's having the impact that you're looking for and expecting. And then if it's not, going back to the drawing board and really trying to understand how you can do better. And so that's part of what zero suicide is sort of that commitment to that sort of enduring effort.
Well, and now that we have some of the technology, as you were mentioning earlier, that we have electronic records, so we're able to flag records for people that are of concern, but also if that assessment, right, or that screen is in the EMR, electronic medical record, you can actually count, right, how many times. And I imagine you can also look at diagnoses or coding, for certain visits that might reflect on this issue, and then what, was there an assessment, or how many assessments have been done. It's fascinating, isn't it? The possibilities of the research.
And the treatment too is to have a plan for someone who screens in positive for suicide risk. So it doesn't just it doesn't end with screening. It ends with what you were saying, in helping them maintain a wellness, helping them not complete the suicide as well. So there has to be a treatment plan and a plan for that patient to be reviewed.
Well, thank you, the three of you, so much for being here with us today. And Debbie Ciavola, who's the Executive Director of Behavioral Health Services at Cape Cod Healthcare. Margaret Deason, Director of the National Strategy for Suicide Prevention Grant, the Massachusetts Department of Mental Health. And Faith Fusco, Psychiatric Nurse Practitioner at Duffy Health Center. Thank you all so much.
Thank you, Heidi.
And thanks for being with us for this episode of Duffy Doings. We'll see you next time.